My topic for today is etomidate. The structure of etomidate is a carboxylated imidazole containing compound. It is chemically unrelated to any other drug. The features of imidazole ring is it is water soluble at acidic pH and lipid soluble at physiological pH. Preparation, it is available in two forms, 35% propylene glycol and lipid emulsion. 35% propylene glycol has got increased incidence of pain on IV injection, whereas lipid emulsion has lesser pain. Single, it, the mechanism of action of etomidate is primary site of action is GABA A receptors, and this action produces hypnosis. Two effects are seen at two different concentration. At clinical doses, there is positive modulation of GABA A receptors. That is, lower dose of GABA is required to activate, lower dose of GABA with the drug is required to activate the receptors. In the other form, in supraclinical doses, the drug, it will directly activate the GABA A receptors. Coming to the pharmacokinetics, the volume of distribution is very large. The pKa is 4.2. It penetrates the brain rapidly, reaching the peak level. The peak level is seen within 1 minute after IV injection. The etomidate drug is 75% protein bound, and it is associated with prompt recovery. The prompt recovery is due to two reasons. One is rapid metabolism and also redistribution of the drug from the brain to the inactive tissues. The metabolism, etomidate has got a high hepatic extraction ratio and also rapid clearance by the liver. It is metabolized in the liver by ester hydrolysis to carboxylic acid. It has got a shorter elimination half-life and rapid clearance, so it is suitable to administer as a single dose or in multiple doses or continuous infusion. The elimination half-life of etomidate is 2 to 5 hours. And coming to the dose of etomidate, induction dose is 0.2 to 0.6 milligram per kg IV. Sedation and analgesia, it is limited to periods of brief sedation because of inhibition of corticosteroid synthesis. At 0.3 milligram per kg, that is the induction dose, one brain arm circulation is 1 minute. The unique property of etomidate, it maintains the hemodynamic stability. Minimum radiation has got cerebral protection and a favorable toxicity profile, and pharmacokinetics of the drugs, it will enable rapid recovery after either single dose or a continuous infusion. Coming to the pharmacodynamics, system-wise we'll see. First is central nervous system. It produces hypnosis by GABA A activity. It is also a potent direct cerebral vasoconstrictor. It decreases the cerebral blood flow and the oxygen consumption by 35 to 50%. And because of this effect, the ICP also decreases. But it may activate the seizure foci. So it is also used for localization of the foci in brain mapping surgeries. In cardiovascular system, because of lack of its effect on sympathetic nervous system and on function of baroreceptors, it maintains the hemodynamic stability. So it is used in valvular or ischemic heart disease, undergoing non-cardiac surgery, and also patients with poor cardiac function. The myocardial oxygen supply to demand ratio is well maintained by etomidate. Coming to the endocrine system, the etomidate, it will inhibit the 11-beta hydroxylase enzyme, so the corticosteroid synthesis decreases. It is also noted that it is a potent steroid synthesis inhibitor, which means that even at induction doses, this effect is seen. In respiratory system, it has got a less effect on ventilation, and it has also got no histamine. It is also associated with no histamine release. The ventilatory drive response to CO2 is also depressed. So since it has no histamine release, it is used in reactive airway diseases. Then yeah, for induction and uses for induction of anesthesia in cardiovascular or reactive airway disease. Cardiovascular is coronary angioplasty or aortic aneurysm repair or any thoracic surgery. For cardiac eversion also it is used. In neurological, giant aneurysmal clipping, short-term sedation in hemodynamically unstable patient, and also used as a treatment in hypercortisolemia. Side effect is uh, the use of etomidate itself is an independent risk factor for emergence delirium. It is also associated with postoperative nausea and vomiting, pain on injection, and also myoclonus or hiccups is also noted. The myoclonus is due to inhibition of the inhibitory pathways. Coming to the newer modalities of etomidate, one is MOCA. MOCA is methoxycarbamyl etomidate. In this compound, there is no adrenal suppression, but there can be accumulation of these compounds on long-term infusion, which can cause delayed recovery. Next is carboetomidate. Uh, this inhibits the 5H, it acts as an antagonist of 5-HT3 receptors. So there is no emetogenic property in this associated with this drug. And also the third is MOC carbo, that is MOC carboetomidate, combining both. On combining both, there is no adrenal suppression and there is no emetogenic property, but it has got a delayed recovery due to accumulation. The last one is cyclopropyl methoxycarbamyl metomidate or dimethyl methoxycarbamyl metomidate. Both these drugs, it increases the potency and also they associated with faster recovery time. But only on animal studies. It is still in the animal studies. That's it, sir.
Okay. So a few points where I can add to this good presentation by you is when you say it acts on the GABA receptors, GABA A receptors, it's better to say that it opens the chloride channel and produces chloride conductance and produces a hyperpolarization state, which causes the inhibition of central nervous system activity, and that is the mode of, that will be the complete mode of action of this drug. So
Okay,
instead
sir.
of just stopping with saying that it either acts as an agonist of GABA transmitter at the GABA A receptor, you must say ultimate what is the mechanism. The main action of GABA is to go and get attached itself to the GABA A receptor, which opens the chloride channel, and the extracellular chloride goes into the cellular neurons and causes a state of increased negativity, which is called the hyperpolarization. Okay.
Yes,
So
sir.
all the drugs like propofol, tipentone, all of them act on the similar manner. So that is the one thing that you have to add here. Then the next point is about why this drug is not that popular, like your propofol, or even some nowadays some people still use tipentone also. But the use of etomidate, as you say, the recent preparations are mainly to overcome the drawbacks of this drug. Like the most feared complication is the adrenocortical suppression, especially in patients if they have a septic focus or if they come for an emergency surgery. At the time, even though it produces excellent cardiovascular stability, the long-term effect of adrenocortical suppression is the main deterrent for its use. And the third thing is the pain on injection. And this adrenocortical suppression activity was detected when etomidate was used in ICU sedation as a prolonged sedation for 2-3 days. Then only they found out that patients were deteriorating, and many deaths happen because of ICU usage of for sedation when for patients on ventilator. That is how they found out that it suppresses the 11 beta hydroxylase and causes the cortical suppression. Yeah? So these are some of the points that you have to alter in your answer. Otherwise, it's well prepared. And any drug or pharmacology question, you have to go like the basics. First, you mention the chemical nature of the drug, which you started correctly. Then you talk about under the headings pharmacodynamics, pharmacokinetics, and then the actual mechanism of action, then the complications, okay? Then the presentation, how it is marketed. So in that order, if you present, I think that will be a better presentation than jumbling up things here and there.